Hi, I'm Elisa Isaac, a member of the Nourishing Life Planning Committee, and I'm very excited to present our next speaker, Dr. Vyvyane Lowe. She's coming to us from Boston, where she's the Chief Visionary and Medical Director of Transform Alliance for Health. There, she and her staff specialize in preventive care and the management of chronic metabolic disease, transforming sick care into health care. She's board certified in obesity medicine and internal medicine and serves on the American Board of Obesity Medicine Exam Writing Board. Dr. Lowe has worked in choreography and dance, and her first novel, Breaking the Tongue, received multiple awards. She's the recipient of a Radcliffe Fellowship and a Guggenheim Fellowship in fiction. Dr. Lowe joins us today to share her expertise in metabolic health with the intention of eliminating the health gaps that plague our communities. Please post your questions for Dr. Lowe in the chat, and please remember that no personal medical questions in this forum. Welcome, Dr. Lowe.
Hello, thank you for having me. Let's see. I am going to share my screen. And voila. Okay, oops. So, today I'm talking about cardiometabolic health. And in particular, I wanted to note some of the differences that we see in ethnicities in terms of our cardiovascular functioning. I know oftentimes when we talk about health, we talk about the racial disparities, and a lot of the focus has been on policy and access to healthcare, which I totally agree needs to be addressed. However, today I thought I would talk specifically about the medical aspects of these differences, simply because I think that there needs to be a huge revision in our medical school curriculum. We need to be talking about this, spending a lot more time doing research to address these differences. And by the way, I just wanted to say happy Juneteenth. I'm honored to be presenting this today. The first time I gave this talk on ethnic differences in cardiometabolic health happened to be, just by luck, MLK weekend. And then this is the second time this year that I'm presenting it, and it's Juneteenth. So I think there's a special meaning there. One last thing I want to say before I actually plunge into my presentation, and that is that you can imagine it's a pretty daunting topic, ethnic differences in cardiometabolic health, because then we're talking about different ethnicities across the globe, right? And then a whole vast of cardiovascular conditions. I don't think, and I don't think anyone expects me to cover everything today, but what I hope to do is to start us thinking about these differences and how they're being, if they're being addressed, especially in the medical community, because we see patients of all diverse types and ethnicities, and we need to start thinking about how we can look at each person from an individual point of view. Oops. So when I'm talking about cardiometabolic health, we're really talking about, I broke it down here, cardio referring to heart and blood vessels, and metabolic referring to the processes of energy management in your body. And when we talk about syndrome, we talk about a cluster of symptoms or diseases that run together. And when you think about cardiometabolic health, traditionally we'll be talking about heart disease and stroke, and anything that might involve, your heart and perhaps even your brain. This is a report that came out, I believe at the end of 2018, that was very startling to me, from the Gillings School of Global Public Health in North Carolina. And what they found was, based on the NHANES data from 2009 to 2016, that 88% of Americans, basically everyone, 88% of Americans have metabolic dysfunction, right? And at the time, the obesity prevalence, I just want to point out, was about 35 to 39%. So that was, you know, from the 2009 and 2006 to 2016 data. In 2018, you'll observe that the prevalence of obesity has risen to 42%. So if, you know, 88% of Americans based on NHANES 2009 to 16 had metabolic dysfunction, I'll bet we're into the 90s now. And when they defined metabolic health, they were looking specifically at waist circumference, fasting glucose levels, triglycerides, which is a type of fat, you can check it from your blood, your HDL or your quote unquote good cholesterol, and also looking at your, you know, systolic blood pressure and diastolic blood pressures. The conclusion was basically that there was pretty bad metabolic health even in normal weight individuals. And I stress this because I often am asked to give a talk on obesity, and my favorite topic is normal weight obesity. A lot of times we walk around, we think we're in good shape, just going by a certain number, and that number often happens to be the weight. But you may have poor metabolic health even if you have normal weight. And this obviously has serious implications for public health. I think it's worse for specific ethnicities. And here we look at the CDC data from 2019 for diabetes. You see that the prevalence for non-Hispanic Blacks, the males would be 13.4%. You know, it's pretty much almost double that of non-Hispanic white men. And we see an increase also with the women. So total, we really see more prevalence of diabetes in American Blacks. And the risk of diabetes is indeed 77% higher in African Americans than in whites. This is actually looking at Hispanic males and females. And again, you see that there is a higher percentage there with Asian Americans, same thing, 11.4% to 8% in whites. With Native Americans, actually, they have the highest diabetes rates, 16% here compared to other ethnicities. And of course, the cardiovascular risks, if we just look at the African American population, right, it would be way higher. 47% of the Black population has at least one form of cardiovascular disease, and that is compared to 36% in the white population. And really, there's a twofold greater stroke mortality and fivefold greater prevalence of end-stage renal disease in African Americans. So these numbers, you might have seen them earlier in the conference, but they are quite you know, difficult for us to wrestle with, because this has been going on for a long time and we really haven't been addressing it. In fact, here, if we look at this paper, they make the point that a 45-year-old African-American man in the Southeast has basically the stroke risk of a 55-year-old white man. And that is also equivalent to a 65-year-old white man in the Midwest. So you can see across the board, bottom of the pyramid there would be an African-American male in terms of, in this case, hypertension. With cardiovascular deaths, you know, 500,000 Black women die yearly from cardiovascular disease. And if we compare that to COVID numbers for 2020, that was already so sobering and painful to see. And then to realize that yearly Black women are dying, you know, at 500,000 of them per year. So I'm sure this, get rid of. I'm sure we have been hearing about metabolic syndrome throughout this conference, but I just wanted to basically touch on this because we hear this a lot now in terms of cardiovascular health. What exactly is metabolic syndrome? When I'm talking to patients, I basically tell them to think of it as insulin resistance. If you're just boil it down to the basics. If you hear someone mention metabolic syndrome, you're thinking about insulin resistance. Now, what exactly does that mean? Let's take a look. We make a hormone called insulin in the pancreas, and this helps to decrease blood glucose by actually having that glucose enter into specific tissues in your body, right? So if you eat something that is, a carbohydrate or has high sugar content, that gets absorbed into your bloodstream. And what happens is with insulin, it helps facilitate this glucose entry into different tissues, such as the liver, the muscle, and the fat specifically, right? These are for at least glucose disposable, glucose transporters. This is where insulin has its effects. Insulin also has an effect on your blood vessel. And what it does is it helps dilate the blood vessel and keeps it healthy, and also helps with this nitric oxide synthase for the formation of something called nitric oxide. Just to go back quickly to insulin resistance, I found this cute little graphic and I thought it was helpful. If you think of insulin as opening the door with this key to allow glucose to enter a cell, when you have insulin resistance, then basically there is no key. The glucose doesn't enter the cell, and instead it attaches itself to, in this case, a red blood cell. All right. And when it does that, it can cause damage to the cell. It can cause damage to any of the tissues that it attaches itself to. Insulin sensitivity is actually quite different depending on your ethnicity, because, we're often used to thinking of it as just, all right, pretty much standard that, you're either insulin resistant or not. But we can see that there's a range of responses in different ethnicities. So what we're seeing here is we're looking at insulin response, right, to someone who's given some glucose. And we have the insulin levels here. And on the bottom axis, what we're seeing is how sensitive they are to that insulin, how much that insulin is really going to respond and let that glucose into the cell, right? So the if you're looking at the bottom axis, if you're going towards the right, then the higher the number, the more sensitive you are. And you'll see that in this case, if we start with the Caucasian population, they're somewhere here in the middle. They, respond to insulin, to glucose, to a glucose load by making a certain amount of insulin, and their sensitivity is somewhere right here in the middle of the graph. If we look at the African American population, and these, by the way, I want to stress, are people who don't have any disease. They're normal, okay? So if you look at the African American population, they start off straight away with a much higher level of insulin. In other words, they hyper respond to that dose of glucose. So that is a hyperinsulinemic response. In addition, compared to the Caucasian population, the sensitivity is lower. So they have more, another way to look at it is they have more insulin resistance, right? They shift it to the left here. Again, in a normal population of East Asians, we see a very different story. They don't make a lot of insulin in response to that glucose load. And yet they have very high sensitivity. So way out here to the right of this curve. So, to a fixed dose of glucose, we can see different responses and different sensitivities in a normal population already. Now, once we see a pre-diabetic population, then what happens with the here, the African American population, is that you'll see a drop in their ability to make insulin now to respond to that glucose load. So in this pre-diabetic condition, we're starting to see disease, and they're now less able to respond with insulin. In addition, they have become even less sensitive to the insulin, so shifted further to the left of the curve. The East Asians are out here, and you see that dramatic swing, right? And this is from a normal state to pre-diabetic state, that insulin sensitivity has dropped dramatically. But in terms of the insulin response, they actually, kind of at the same level, almost a flat line there, right? With the Caucasian population shifted left in terms of sensitivity and a slight drop in the insulin levels. Now, by the time we get to flat out type 2 diabetes, then we see with the African American population that we have actually very little sensitivity here. So very insulin resistant, another way to look at it. And again, much lower insulin levels. And it's the same with, by this time, they're pretty much on par with the Caucasian population. The East Asians are, again, shifted more to the left, but look at that big drop now in insulin formation. They can't really produce much insulin at that point. One might think that they're approaching, the insulin level, they're kind of looking like the type 1 diabetics at that point, right? So very interesting differences here in terms of their insulin sensitivity and response. I want to jump back to nitric oxide. And this is a molecule that is produced in different parts of your body. In this case, in the lining of your blood vessels. We call those the endothelial cells. And there is an enzyme there called nitric oxide synthase. And it will take this amino acid arginine and eventually convert it to nitric oxide. And nitric oxide has wonderful effects on your blood vessel. It will help dilate your blood vessels, right? And it inhibits stickiness of platelets and adhesions. So nice flow of blood, inhibits adhesion molecules. So again, promoting nice smooth flow and less stickiness in your blood. It can act as a neurotransmitter, and it also modulates cells in your immune system. With insulin resistance, what happens is you will have decreased nitric oxide synthase. So that means you make less of that wonderful nitric oxide. And instead you make this substance called endothelin-1, which pretty much has reverse effects. Instead of dilating those blood vessels, we're going to vasoconstrict and make those blood vessels, a lot tighter. So with African Americans, there is an impaired ability to make nitric oxide to begin with. So across the board, we see that there's a decreased endothelial ability to make this molecule. And as a result, then you don't get that nice, smooth muscle vasodilation when you have that nitric oxide forming. And this nitric oxide bioavailability is seen across the lifespan. So we're talking from the very young to the very old, just hands down throughout the lifespan, much decreased nitric oxide. And this is going to have some implications, not just in terms of insulin resistance, but also with their blood pressure, right? Because I just told you that nitric oxide is a potent vasodilator, and that will keep the blood vessels nice and open. Now, if you have much less nitric oxide, then you have more vasoconstriction, and that can lead to high blood pressure, which, if untreated, will lead to strokes, kidney disease, heart failure, and even dementia. And let's look here at the prevalence of hypertension. This was data from 2009 to 2012 from American Heart. And in non-Hispanic Blacks, and you see the breakdown male, female, prevalence is like almost 45% in the males and 46% in the females. Non-Hispanic whites, 32.9%, in males, 31.1%. And then in Hispanics, 29.6 and 29.9. That was 2009 to 2012. If we look at more recent data, 2013 to 16, you see that unfortunately that prevalence has gone up, 54% hypertension prevalence in the Black population. And we see actually with the Asians also going up, and increase in the Hispanic population, whites. Across the board, we see an increase, but you can see that top of the list would be African Americans. Now, let's also look at reactive oxygen species, because this might be part of the mechanism that's causing some of this dysfunction, right? Any molecule that has oxygen that has an unpaired electron is called a free radical. And when you have that situation, that molecule is very unstable, very, very reactive, right? So you don't really want to have a lot of these. It doesn't just have to be oxygen species. They can be nitrogen species. They can be lipid species. But, you know, commonly we refer to these free radicals as reactive oxygen species. So you have these molecules with the unpaired electrons out here, very reactive. And because of that instability and reactivity, they cause damage to DNA, RNA, and pretty much any tissue that they come into contact with, and they can cause cell death. As I said, they may damage lipids, proteins, DNA, RNA, they cause aging, they're involved with cognitive dysfunction or dementia, male infertility, cancer, so all pretty bad stuff, right? And when we talk about oxidative stress, and we'll come back to this a few times, when we talk about oxidative stress, what we're really talking about is this balance between the formation of these free radicals and antioxidant activity in your body, right? So antioxidant is reversing the formation, the damage caused by these reactive species. So when you think about oxidative stress, again, think of this balance. And when we talk about increased oxidative stress, we're basically saying the balance is off. And you're making a lot more of these unstable molecules, the reactive molecules that will cause tissue damage. Now we have these transmembrane enzymes, you know, NADPH oxidases, I call them NOx here. They are key ROS producers. They form a lot of free radicals. And we see that they actually happen to be elevated in African Americans. So we're causing a lot more of this oxidative stress and more damage to tissue. In addition, we see that this molecule, xanthine oxidase, right, is an enzyme that's involved in the formation of uric acid, which is also implicated in metabolic syndrome. And we form a lot more of these free radicals when we have this enzyme active. Okay, I want you to keep these two enzymes in mind, the NOx and the xanthine oxidase, because when we look at the next graph, you'll see why. So I'll walk you through this. What we're looking at on the y-axis is cardiovascular conductance, and what that means is how easily blood is flowing through the bed of blood vessels. Okay, and if you have high conductance, then it's flowing well and easily. If you have low conductance, then there's resistance. It's really hard for that blood to flow through. So in this case, you see that the bars in black are controls. The bars in white are people who are given this chemical, aposinin, and this is a NOx inhibitor. In other words, it's preventing that NOx enzyme and therefore preventing those free radicals. And in the striped bars, they're given allopurinol, which inhibits that xanthine oxidase, another free radical producer, right? So these are two different chemicals that are given to these subjects, but essentially to decrease these free radicals, right? And in the white population, you notice here's the conductance, this is how easily blood flows through a bed of blood vessels in that population. When you give the inhibitors that will actually decrease the free radical formation, you don't see much difference. You can see that they're pretty much equal here. The blood is still flowing as it was before. If you look at a population of Blacks, then we know, first of all, that even in the control state, we have lower conductance. So there's already more resistance in blood flow just to start off with. However, when you give those chemicals that will inhibit the free radical formation, you see that the flow increases, right? In this case, with aposinin, the NOx inhibitor, this is the xanthine oxidase inhibitor. And once you give that and you inhibit free radical formation, you see that we increase blood flow in this Black population. This graph, you know, what they have done is they've given everyone on both sides, right? Everyone was given a chemical that actually inhibits nitric oxide synthase. So this chemical prevents formation of nitric oxide, or decreases greatly the formation of nitric oxide in your blood vessel. So from the start, they give you that. And you see now, even in the controls, there's less blood flow because there's less nitric oxide. All right. And then if you give those free radical chemicals, inhibitors in the white population, again, not much change. So much lower blood flow, especially compared to this, right? Now we have a nitric oxide synthase inhibitor. We're not making a lot of nitric oxide, and we have not a lot of blood flow. But when you inhibit the free radical formation, you see that we do get an increase, meaning that they somehow are under more oxidative stress just to begin with. And then we do see differences between Black men and Black women even. I'm just keeping an eye on the time, so I'm going to just skip those graphs and basically come down to the baseline is there might be more oxidative stress seen in Black men, and but we might also have more of this endothelin 1 formation, which causes vasoconstriction in Black women. So not only are there ethnic differences, there are also gender differences within ethnicities that we have to pay attention to. All right, another sort of metabolic disease that we should be looking at is obesity. This is NHANES data from very recent 2017 to 2018, right? And you'll see the legend here, the dark blue non-Hispanic white, and then this lighter blue non-Hispanic Black, the darker green non-Hispanic Asian, and then Hispanic in the lighter green. And you'll already see right here total in terms of obesity for Blacks is about almost 50%. And these graphs are just telling you the same thing. I'll go through them quickly. One thing I want to stress is that we often think of obesity as just weight alone. And I want to point out that there are some nuances here that we have to pay attention to. When I think of obesity, I think in terms of obviously fat mass, so the amount of fat, but I also think about dysfunctional fat. In other words, okay, given this amount of fat, how much of the fat is functional and how much of it is dysfunctional? I also want to know the fat distribution, because where it is, that compartmentalization of fat will tell me a lot about its function and whether it is causing inflammation or not. So, you know, the differences here, while we do see differences in obesity prevalence in ethnicities, I want to point out that a lot of this data looks primarily at the BMI, which is just your weight over height squared in metric units, right? And it's not taking into account your body composition. So I don't feel is as useful because we're missing quite a big piece of the picture. We just get the mass part. We don't get the function part, and we don't get the distribution part. We're really not getting the body composition. So there needs to be a lot more work done, not just in obesity, but looking at body composition across different ethnicities. Now, very quickly on to vitamin D. Like I said, I'm trying to give you just kind of a broad sweep of some of the categories we can look at in terms of these ethnic differences. With vitamin D, we know that it's quite well documented that it's related to many cardiovascular complications if there is deficiency in vitamin D. And I want to remind people that it is considered a pro-hormone. We have to get it from an outside source if we don't make enough in our skin. And then it has its effects throughout the body. And this slide is just to show that the VDR is a vitamin D receptor, right? Which is, first of all, present in all cells of your body. So just think about that. If you have vitamin deficiency, then that's going to impact every cell in your body, because every cell in your body has vitamin D receptors. And by the way, these are intracellular receptors, which means they're not on the surface of the cell, they are inside the cell. And what's special about intracellular receptors is that they often will be involved with gene transcription. So when vitamin D binds, it will, with the receptor inside the cell, it can impact gene transcription in the nucleus. And that's why it's so powerful. If we look at vitamin D in African Americans, we note that most young, healthy Blacks do not achieve optimal levels at any time of the year. Any time of the year. I know we're going into summer, it's the solstice, but no, we're not going to be getting enough even over the summer. And even in Africa, right, I made a point to put this in the slide that vitamin D deficiency is high. If we look at Native Americans, 2/3 of Native Americans are deficient, and almost 1/3 has severe deficiency. With Hispanic Americans, almost 30% are D deficient, and half of Asian Americans are D deficient. As I mentioned, a lot of people point out to me that this time of the year, they're going out and getting their vitamin D in the sun. But that's not so easy. If you live where I live, I'm in the Boston area, and it's above 32, anywhere above 32, 35 degrees north or south, you're going to have trouble getting enough of these UVBs that are necessary for that vitamin D formation in your skin. So because of the angle at which the sun, is at different times of the year, right, then you have more or less UVB exposure, again, depending on time of year. In the summer here in Boston, yeah, we would have a bit more. And if I wanted to get my vitamin D from the sun, I need to be outside around between 11 a.m. and 3 p.m. Because that's when I will get enough UVB. And then I would have to pretty much be in my bathing suit, right? Expose large areas back. Most of the time, if you go out, you're on your lunch break, you have your arms exposed maybe, and you're sitting in the sun, and you may enjoy that warmth, but you really don't have enough surface area to be making much vitamin D. All right, next would be sleep, keeping an eye on the time. This is something that we don't think about very often, but sleep duration is linked to cardiovascular disease. We know that if you're not sleeping enough, or you have poor quality sleep, you're much more likely to be obese, you're much more likely to be diabetic, and you're much more likely to have neurodegenerative diseases such as Alzheimer's. In this case, I want to focus on one aspect of sleep called nocturnal dipping. Right, when you get to, let's say, deep sleep, you should have a drop in your heart rate, and you should have the lowest blood pressure of the day. So this is called nocturnal blood pressure dipping. So the blood pressure drops, and that's a good sign when you're in deep sleep. What we've noted is that African Americans have higher nocturnal blood pressures. So they're not getting that nice dip of blood pressure in deep sleep. And we see this by age 10, and there's already this blunted dipper response in the adolescents, okay? I think what is really fascinating to me is that this is not observed in people of African heritage outside the US. And this is primarily seen in African Americans, this lack of nocturnal dipping. And we can talk about, maybe in the question and answer session, we can speculate on some of the reasons, but I just thought this was a fascinating point here. When you have that absence of that dipping, you are at increased risk of enlargement of the heart, that's cardiac hypertrophy, silent strokes, and you may be leaking protein in your urine, which is a sign of kidney dysfunction. So it's not a good thing. And in fact, every 5% lessening of that dipping confers a 20% increase in risk of cardiovascular mortality. And that is quite sobering, right? So if you lose that dipping, it can have a huge impact on your cardiovascular mortality. And, we can speculate, but we see that African Americans are 2 times as likely to have non-dipping blood profiles, and they have more sleep disturbances. So shorter sleep, more fragmented sleep, less of the slow wave sleep, and more obstructive sleep apnea. So briefly, what are some of the lifestyle recommendations that I would make to counter some of these differences? Obviously, we want to be avoiding any poor nutrition. So processed foods are out. I don't think I have to say that to this audience. As much as possible, my belief is to eat foods of one ingredient. So, broccoli, chicken, one ingredients. Avoid toxins such as smoking and alcohol. Many people don't realize this, but alcohol is a class 1 carcinogen. Other class 1 carcinogens are tobacco and asbestos. So, we would do well to definitely avoid those kinds of environmental toxins. The chronic stress here can have an impact because chronic stress will raise your oxidative stress. And you remember we would have then an imbalance, more free radical formation, right? So decreasing chronic stress can be very helpful in decreasing general oxidative stress. And obviously we want to avoid infections if we can. We can't always do that. We want to avoid physical inactivity. So the more active we are, the more helpful in terms of keeping our blood vessels healthy, in terms of decreasing our risk for insulin resistance and preserving that metabolic health. And of course, we want to address any vitamin D deficiencies, make sure that we get enough supplementation. In this case, depending on where you live, it will be very hard. I grew up in the equatorial tropics, and you would think that we would get a lot of vitamin D, but then most people avoided the sun like the plague because it was just way too hot. So, in the end, we all needed our vitamin D supplementation anyway. And then avoid circadian disruption, which is to say, really address your sleep. In terms of addressing that oxidative stress, we could ingest more antioxidants. So this is vitamin C, which is a well-known antioxidant. This is a study that basically showed that it's looking at the levels of vitamin C in your blood and then comparing it with your blood pressure, systolic blood pressure. And as you go across the quartiles here, in quartile 4 would be the highest vitamin C content, and here would be the lowest. Quartile 1 would be the lowest vitamin C content. And basically, the more vitamin C, right, the lower the blood pressure. And, this is another study showing that, and this one, it's an old study, but they were able to, with vitamin C supplementation, drop the systolic blood pressure by as much as 10 millimeters of mercury, which is quite a lot, right? And these are other, sort of effects that we've seen. If you give vitamin C, you can facilitate more of that vasodilation and help decrease that blood pressure. And by the way, about 40% of Americans are below this estimated average requirement for vitamin C, 40%. I have seen flat out scurvy in my population of patients. It's not that uncommon. Nitrate intake is really important, and the best source of nitrates would be these nice green leafy vegetables, especially important because what happens is these nitrates then can eventually be converted to nitric oxide, which is going to help your vasodilation. Now, one point I want to bring across here, which I found pretty interesting, and this seems to be quite well known amongst the dentists, but when I ask other doctors, they're not quite aware of it. That if you use any over-the-counter mouthwash with alcohol or any antibacterial, then you're going to increase your blood pressure because you're going to decrease nitric oxide formation. So essentially, back to the gut microbiome, we often think of lower gut. We don't often think of the upper gut, which is in the mouth, but we have these bacteria in the mouth. And when we eat the nitrates via the green leafy vegetables, they can convert the nitrates to nitrites, which then can get absorbed, and then they're carried around in the blood, and eventually they will be converted to nitric oxide, right? If we kill those bacteria with mouthwash, with antibacterial sort of, either toothpaste or other antibacterial oral agents, then we kill those bacteria and then we lose this effect. And that can have a big effect on your blood pressure, quite noticeable. And if you are in a population that already has blunted nitric oxide production, as in African Americans, then we really need to make sure that we prioritize the flora, the mouth flora. There's another study showing that, pretty well known. I think I will end here and see if you have any questions.
We do have some questions. Cynthia asks if you could please say more about dysfunctional fat, maybe lipodystrophy, and how this plays into metabolic syndrome and how one can manage it.
So lipodystrophy is quite different. It's the lack of fat, but we're so used to thinking putting fat in the villain box, right? But we do need fat, and it's really important that we have healthy fat. We have two main compartments where we see fat. One is the subcutaneous, which is under the skin. And then we have this whole other category called ectopic fat. And ectopic just means it's not where it should be. And one subset of ectopic fat is what we call the visceral fat. And this is fat inside the abdominal cavity. But other ectopic fat may be fat that are in your organs, such as in your liver, in your heart, in your pancreas, just name the organ, you could have fat there. I saw a question earlier about asthma. And what people don't realize is that we do have fat, ectopic fat, in the airways, in the lungs. And when you get rid of that ectopic fat, then actually the asthma symptoms go away. And most pulmonologists will want that fat to be gone, right? So with regards to the fat, the ectopic fat, it is highly inflammatory. It secretes all kinds of inflammatory cytokines, and it promotes the formation of cancers. 40% of cancers globally are associated with this very toxic fat. So, it's a nuance about fat distribution that people don't often talk about or consider, but I think it's highly important. Now, subcutaneous fat eventually can also become dysfunctional, but by and large, it is almost acting like a reservoir and a protective sink, right? Because if it goes inside, into the viscera, for example, and into organs, then we're really in trouble.
Okay. Marjorie asks, the study that showed the correlation between vitamin C intake and a reduction in hypertension, was that vitamin C from whole foods or was it from a supplement?
Supplement they infused, okay? So if you remember the 4 quartiles, and I showed that if you had higher dose, you had less, your systolic blood pressure was lower, right? Now, the first quartile, which was the lowest content of vitamin C, I believe was 0.5 milligrams, which is equivalent to 1 orange. Yeah, not a lot. That's right. So unless you have an orange grove and you're ready to just spend your whole day consuming oranges, probably not the way to go. We do not make vitamin C, so we have to ingest it, right? Most animals do. Most animals make vitamin C. We are like guinea pigs and some other primates, and we have all the enzymes except the last one. So we don't make that vitamin C. And so we have to get it either food sources or supplementation. Now, in the case of where they actually infuse, I believe they went to 1 gram a day. And I think the higher doses were more towards 1 to 2 grams a day. So remember, grams, okay? So versus milligrams. So 1 gram would be 1,000 milligrams. And that's really hard to get from foods daily.
Dr. Lowe, you said something about we might get into in this period. Some of these things you see differences in African Americans versus people who live in Africa.
Correct.
But the nocturnal dipping, for example. And I thought I would ask you about that, if you would talk more about that. And I was thinking about the insulin resistance versus insulin sensitivity. Was that maybe something that is
So
different?
that is across people, across the board for people of African heritage. So you do see that in Africans from Africa, Africans in the Caribbean, for example, right? But with the nocturnal dipping, that is specific. So if you had Africans who are living in England, for example, you don't see that, right? So I do think my own speculation, because I don't know for sure, I haven't seen any studies to try to pinpoint the reason. My speculation is that this is an indication of increased oxidative stress, probably from increased chronic stress. And that suggests to me an environmental exposure. And that could be, you know, in terms of pollution and nutrition, but it could also be in terms of our social systems.
Systemic racism.
Yes.
And trauma.
Yes.
Rachel asks, do you think the unique trauma that African Americans have experienced in the US and getting here is part of the cause of some of these predispositions?
I personally think so. And it's not just trauma, it is unrelenting, right?
Right. It's not just
the
past.
continuation of, yeah.
Right.
Absolutely. I'm glad someone asked.
Yes. We have a lot of work to do.
Yes.
Yeah. Dr. Lowe, I have to, when I look at your website, I have to think that there's a spiritual component there when you're the chief visionary of your practice. And I wondered if you could talk a little bit about that.
Well, a lot of what we do is basically help people change their lifestyles, and you can't do that without addressing the whole person, right? We have a whole team approach, and I can't say it's me, but I have a wonderful team, and they're here to help our patients in terms of lifestyle and behavior change. And once we talk about lifestyle and behavior change, we are also talking about changing our interactions and relationships in the broader world, right? If you note that Gillings study, 88% of Americans have metabolic dysfunction. So as we treat our patients and reverse that metabolic dysfunction and bring them into the 12%, I tell my patients, by definition, you are abnormal. You are outside the norm. And this is going to be hard. And it certainly is in terms of the pressures around foods, pressures around certain behaviors, right? So, you know, we see that if we don't address the whole person, all aspects, then we're not really going to help them have meaningful change.
Dr. Kukazela has chatted that in his practice, they ask about trauma at every visit, because if it's not addressed, you can't help people. And then I suppose there is, you know, the trauma of history that we can all learn about before we even, you know, we can learn our history, and that might help.
Yeah, there's absolutely that.
Dr. Lowe, I wondered if you could talk a little bit about how your humanities side, the writing, the choreography, the dancing, how does that inform your practice as a physician?
I think it's invaluable because, for example, I do use narrative writing with my patients. I do use movement a lot with my patients. So I have a whole lecture on movement and cognition. So I utilize the movement and to help people with neuroplasticity, for example, and also for dealing with stress. So all those components, dance and writing and connecting with our own humanity, really, I think, helps ground the patient, helps ground me in my practice. But I also find them to be really useful tools, very practical tools in helping address some of these issues.
And so you're still writing for yourself?
Currently working on a nonfiction book. I have a fiction novel that's shelved, but some people have kind of been trying to persuade me to revive it, and I might at that time, but I really would like to finish my nonfiction book first. And that does involve metabolic dysfunction.
Oh, great. Okay. Well, we can all look forward to hearing about that and hearing that come out.
Thank you.